All right, so I'm Shelly Leacock, and let's dive in. All right, we have, here's our agenda for today. So we're going to go through our learning objectives, some introduction and background, cover medical device incidents, reporting investigations, how VA investigates incidents, our incident investigation data, and conclusions and questions, of course. We have a lot of ground to cover, so we're probably going to take up the full time. All right. But if there are any questions, you know, Hank and I are not, we'd like to run a relaxed presentation, or we want this to be a discussion, not just a presentation. So just go ahead and interject, raise your hand throughout, and we will address questions as you have them, rather than holding them till the end when you might forget. All right, so our learning objectives are to understand the importance of medical device incident investigations to the culture of safety, learn why and how to conduct your own incident investigations, and review the steps of a successful incident investigation following the award-winning VA HTM Incident Investigation Guidebook. Our guidebook will soon be available on the ACCE website. So we've made it, we took out all the VA specific stuff and made a version that we can share with all of you. All right, so into the introductions and background. I'm Shelly Leacock. I've been a biomedical engineer in the VA since 2004, so I'm going on my 22nd year. And I worked at a facility for the first bit of my career, then moved on to the regional level, and I've been at the national level with our HTM program office since 2012. And I'm involved in a bunch of committees through AMI and I used to be on the ACCE board, not anymore, but an FPA and ECRI and AMI committees. Okay, go ahead, Hank.
Thank you. And I'm Hank Stankiewicz. I go by Hank. I've worked with the VA a little bit longer than Shelly, celebrating my 50th year of working either for the VA or with the VA. I retired after a couple of, like 3 decades of work with the VA. Retirement didn't take, and I came back, and Sigma Health Consulting was kind enough to hire me back, and Shelly was kind enough to hire me back. I've done a lot of work with the VA and also with the private sector, both with patient safety, which is what we're here to do today, but also with program assessments, organizational alignment, whatnot. And Sigma Health Consulting, for those of you, if you're interested, up front, I have a little flyer of what our company does. We're a small business, but there's 22 people of us. Our Vice President, Kenny Calavito's in the room. Diana and Mark, my colleagues in the room. I appreciate you guys coming. And Diana, of course, helped me with this presentation. But if you're interested in seeing more of what we can do, we're augmenting the VA staff. As you know, you guys and gals, we're very fortunate. There's a shortage category for all of us, and it's terrific that we're still needed at this point in my career. Like Shelly said, I'm involved in many things like Shelly with the ACC and AMI and the local Nesky Society, and I encourage all of you to do that also. It really fulfills your career aspirations.
Yeah. So. And I'll give a plug for Kenny as well. He's starting up a DC Biomedical Association. So if you are in the DC area and would like to get plugged in with a local biomed association, talk to Kenny afterwards. Okay. All right, so who's the VA? Well, you all know there's VA hospitals out there. It's funny though, like I live in a small community in Northern Washington now, and as I meet people and tell them what I do, some people are like, oh, the VA has hospitals? So we have 170 hospitals, or 171 medical centers, 1 central office. We have 18 regions. We're consolidating those regions at this time. We're going through a big reorganization, but that's what it is right now. We have around 2,200, these numbers are a tiny bit outdated, 2,200 biomedical engineering professionals, over $10 billion of healthcare technology across our enterprise, and over 900,000 medical devices and clinical systems. All right, so let's dive into incidents.
Just my hand off. Thank you. So the first thing you need to know, medical device incidents, what are we talking about? I need to make sure we're all at the same level. And when we do this discussion, I often find that folks think of medical devices, a ventilator, anesthesia machine, et cetera, because we're all techies, we're all in the biomed community. But don't forget, it's It's anything used in the diagnosis, treatment, or physiological monitoring of a patient, and anything that's not a drug, biological, or food. So, you know, beds, you know, there's some always discussion in the HTM community of beds, medical equipment. They sure are. But even IV tubing and tongue depressors. Now, those things we typically will not get involved in. And Shelly does a phenomenal job with the VA on recalls. We've never quite seen a recall on a tongue depressor, but could happen, maybe an infection control problem or splintering. So keep in mind, when we're talking about medical device incidents, it's the whole full gamut. In the HTM community in the VA, we typically only deal with the hard equipment like the ventilators, the beds, etc. We don't typically get involved in the consumables, although we are more now working with our National Center for Patient Safety. But for the most part, and you'll see some stats at the back of the presentation, it's what I call real equipment. Anyway, what is a medical device incident? It's anything it's an event that could have resulted in harm or did result in harm, and it involved a medical device. In any of your hospitals, those of you who work in a hospital, you know there's countless problems with patients and visitors, slips, falls in the wintertime in New England. You know, we always lose a couple of patients and employees with slipping on ice. We don't get involved in that, obviously. But if there's a patient on a ventilator, the ventilator alarm fails, things like that, that's what we get involved in. All right, so medical devices, you know, depending on the era, and you know, you heard yesterday presentation, well, some of you did on the new Joint Commission regs. Amy's got a keynote speaker on the new Joint Commission regs. You know, they have different terms now: a no harm event, a near miss event, a close call event, and that's could have resulted in harm. But then we talk about an incident that did result in death, permanent harm, or severe temporary harm. It's a sentinel event. And, you know, we want to, fortunately, and like Shelly says, we cover 171,000 clinics. We don't get a sentinel event very often in the VA, fortunately. I hope I don't jinx us. This is just some VA language that you may hear when we talk about it. You know, we talk about repairable medical devices and reusable medical devices and disposable medical devices. Again, that's just some, you know, for us, when we categorize an incident, we want to know what it is. So for us stats, we know where we have to put our level of effort. And why do we do this? Well, I thought it was pertinent since we're in Baltimore to quote a Johns Hopkins study. Gaps occur all the time. And in this case, at least in 2018, hospital errors were the third leading cause of death in the country. That staggered me when I saw that. I had no idea that it was that dramatic. But again, that's pharmaceuticals, medication errors, things like that. And so again, why do you want to investigate it? These gaps in the process or lack of investigation resources, it leaves your organization vulnerable to reoccurrence. We don't have to worry about in the VA costly claims too much. The veterans are pretty good with us. They don't typically sue us, which is very kind of them. But again, the perception, you don't want to read, if you're a veteran, you have a family member that's a veteran, you don't want to read in the newspaper about a veteran being injured in your hospital. And you know, we always laugh if a veteran gets injured at the Baltimore VA, it makes the newspapers in Boston. Everybody worries about the Boston VA. So that even though we're a loose affiliation of hospitals, everybody thinks of it as just one VA. And I'm going to turn it back to my colleague, Shelly.
Okay, thank you. All right, so we all know what the FDA is, and the FDA has a program for medical device incident reporting called MedWatch. Hopefully you've all heard of MedWatch, and we can all go into MedWatch and search for similar incidents that may have occurred, or if you're purchasing new equipment, you can use the MedWatch search to look for things that might that you may want to be aware of and ask manufacturers about as you're diving into your market research. So staff can voluntarily report actual or potential problems, so close calls, near miss, or actual events through the MedWatch program. And those are stored then in the MOD database, which is where you would search for other incidents of similar types. Hospitals must report serious injuries or deaths, and there's a slightly different process for that, but it's the same form essentially on the FDA website. And then manufacturers must report malfunctions, serious injuries, and deaths as well. So the FDA plays a major role in the regulation of our medical devices across the United States, and they classify medical devices based on the risks the device poses to the patient or user. A class 1 device is really a simple device, a tongue depressor, as Hank talked about, something that's not likely to cause serious injury or death, and it's generally safe and effective for human use with general controls. A class 2 device is where a lot of our medical equipment falls, as well as class 3 devices. Class 2 devices have performance standards and can assure the device is safe and effective for human use as well. They're a little bit more complex though. And then a class 3 device is your most complex devices, your anesthesia machines, your heart-lung bypass, things of that nature where it's sustaining human life or is of substantial importance in preventing impairment of health and can present a potential unreasonable risk of injury. Okay. MedWatch. We mentioned the FDA MOD database where all your MedWatch reports are stored, and anyone who's filed any MedWatch report can then search in the MOD database for that report or for other similar reports. The MOD database houses searchable medical device reports, MDRs, that are submitted to the FDA by mandatory reporters and voluntary reporters, such as healthcare professionals and consumers. The FDA receives several hundred thousands of MDRs every year, and these can include suspected device-associated deaths, injuries, serious injuries, and malfunctions. And although the medical device reports are a valuable source of information, this passive surveillance system has limitations. Often the data is incomplete, not many details are included. It's hard to really know what you're reading or looking at. So the FDA actually has another program where you can report in your medical device incidents, and it's called MedSun. You have to sign up to be a MedSun member, and I highly encourage all of you to look into this. So you apply to be a MedSun member, and then those reports get more attention from the FDA for quicker resolution with your manufacturers. MedSun is a clinical community that has valuable firsthand knowledge, critical to help the FDA protect the public health. Any reports that are sent into the MedSun program are followed up on by an FDA employee, and they're also sent to the manufacturer, and the manufacturers respond very quickly with a MedSun report, whereas they don't really with the MOD report or a MedWatch report. Interactions with the FDA about reports as needed to ensure that the reporter's perspective is relayed to the FDA. So when we file a report, they email us or call us and ask for more details most often. MedSun reports are prioritized and received individual review with expedited internal timelines. And then, as we've talked about, the FDA and the manufacturers follow up a lot faster with a MedSun report. We get feedback from reporting outcomes, and that's shared with all of the MedSun user facilities. They publish a monthly report, and that can be quite valuable. And then manufacturers do respond to those MedSun reports. So when do we report in incidents to MedSun? Well, we do this not for every incident, but we report incidents into MedSun when it has a trend, pattern, or cluster of failures, exhibits usability challenges where design change would prevent the failure mode. It could have led or did lead to serious injury or death. The incident involves an issue where the public sector would benefit from having knowledge of it, and or we're lacking a good response from the manufacturer, because these reports do get more heavy attention by the FDA and the manufacturers. All right, so when to report and how do you report? You all have your internal reporting systems, I'm sure. In the VA, that's called JPSR or JASPER, and DoD uses the same reporting system. But if you're not in the VA or DoD, I'm sure your local facility or enterprise system has internal reporting mechanisms. And then for FDA, there's a great table here of what to report, how you report it, to whom and when. So device-related serious injuries have to be reported through FDA Form 3500A to the manufacturer and the FDA within 10 business days of the event. Device-related deaths, same thing, but it's a different form. It's just Form 3500, I believe. And then the annual summary of deaths and serious injuries, that's FDA Form 3419. That's not something that our HTM community files. That's going to be more your patient safety professionals at your facility or your quality management department or something of that sort. And then near misses and injuries can be reported at any time, no specified timeline through the MedWatch and MOD programs. Okay, so VA local investigations of incidents. Or are you taking this?
That's more.
Okay.
Thank you.
I don't see slide numbers.
We
so
tried, yeah, that's why I stood up.
Yeah.
So in the test at the end of the session, make sure you remember the difference between MedSun and MedWatch. It's a very important difference because, again, remember the slide, and I just want to stress this, is anybody can submit to the MedWatch. So and it can be very biased. It could be just, hey, this pump didn't work. It's a piece of crap. You could get that. And then people will, yeah, I'm sure you've seen that. So you have to be so careful reading through that because especially the clinical staff will look at that and say, oh, this device is the real problem, when really it just was a lack of understanding. But the MedSun that Shelly talked about is terrific because it's really, really checked and verified. And then the manufacturer really works closely with it. So it's a terrific difference to make note of. So again, some people say they evaluate incidents because it's a Joint Commission requirement. That's something the inspector may ask you. But it's paramount to investigate an incident when it happens in your hospital. And why do you want to do that? And you want to improve your culture of patient safety. You want to promote that culture of safety. You want to prevent another similar incident from occurring. Everybody is human. We all make mistakes. Every device will fail once. We don't want to have that happen twice or three times. The strength of the VA system, when I talk about the Baltimore VA and the Boston VA, if there's an incident in the Baltimore VA, we investigate it, we find out what happened, we disseminate that information to everyone, so the same problem doesn't happen in Boston, doesn't happen in Minneapolis, doesn't happen at the Capital VA. And the other thing which I've learned over the 12 years working with Shelly on these incident investigations are, you want to reassure the clinical staff that the equipment's safe. Often after they have a horrific incident with a device, they may not trust it, and they may want to, no, I don't want to use that pump, I don't want to use that ventilator. So you really want to show them what you've done to get to the root cause and maybe the secondary cause of the incident, so they gain confidence in using that equipment. And frankly, there's nothing worse than as I get from middle age to elderly, and I'm laying in a bed with the nurse and she doesn't know how to use the equipment. That doesn't give you a lot of confidence when you're laying in that bed and she's banging on the side of the infusion pump saying this damn thing doesn't work. And then I'm trying to tell her that she loaded the cassette wrong. Now, what do? Shelly and I work for headquarters. It's the big office in Washington, D.C. in the shadow of the White House. This is the role we have. So the incident just doesn't stay in Baltimore. It comes into the program office, into Shelly's office. And when they report it, we assist the sites. Often we have new people running a program. You don't see a lot of incidents in the hospital, knock on wood. So what do? We come in and assist them. And we offer our assistance to do that. And I'll keep saying assistance because it's critical. And again, we want to look at that one incident that occurred to see if it has national implications. And we want to mitigate that risk across the entire spectrum of the VA. Again, we assist when the hospital reports it, when they want our assistance, and again, if it has potential risks. All right, so this is how the VA investigates incidents. This is my last slide, then I'll turn it over to Shelly. So Shelly referred to this guidebook. This is an excellent guidebook. For those of you who know the inner workings of the politics of AMI and ACC, they tend to work together to support us, but sometimes they have a little bit different viewpoint. Way back when, has it been 10 years now, Shelly, you think, that we published? the first guidebook?
2018, yeah.
So about 8 years ago, we published the first guidebook. We've just come out with a brand new one, the 2025 edition. Diana helped us a lot with that, with the formatting and stuff. It is available in the public domain, and it steps you through how to conduct an incident investigation. And the reason I put out ACC and Amy is that year that the first guidebook was published, both Amy and ACC recognized Shelly and our National Center for Patient Safety with a National Patient Safety Award from both groups. And that's fairly unprecedented. So that's how well our community accepted that this book. And what Shelly's going to go through now is to go through the guidebook and the 10 steps you can use at your hospital to do a successful investigation.
Okay. So we're going to step through the critical steps of an incident investigation. Step 1 is incident response. So you get a call, something happened. Maybe, hopefully it just happened and while you're there, and it's not a night or weekend, but often that is the case where we find out about something much later. But in any event, when you get the call that something has happened with a medical device, an event has occurred that is untoward, we want to dispatch the medical device incident response team, grab your incident checklist, which we'll go through here in a minute, and your go bag, which we'll talk about in a minute as well. Take emergency measures, just like when we all take our CPR training, what do you do first? Anyone know? Make sure the scene is safe. Yeah, that's the first thing you do. If you're responding to a critical incident, maybe a pipe burst in the MRI suite and they had a patient on the table, is the scene safe? Maybe, maybe not. I don't know. Maybe there's sparks flying because there's water and electricity everywhere. So you got to make sure the scene is safe first. And then take your measures to minimize the threat of harm to patients and staff, and obviously provide backups or spares if needed. We recently had an incident reported where a facility has 2 balloon pumps, and the one was not working in the middle of the case. They went to grab the other one, and guess what? It wasn't working either. It had some improper setup or wasn't set up correctly, and so they weren't able to use either. So we really need to make sure we have that backup equipment and that the backup equipment is working properly on a regular basis. Okay, let's talk about the checklist. So we have a checklist that we're going to go through, and it's a reminder of the common actions that should be taken by VA or by any personnel when responding to a medical device system incident. The checklist may not be all-inclusive, but it's a great start if nothing else. This checklist could easily be put on all of your staff's work carts or whatever they take, in their tool bag to have available when something occurs. So first of all, I know this writing is very tiny, but first we want to respond to the scene. So grab your go bag, assemble your team, and confirm the situation is stabilized. Secure and sequester. So we want to secure any medical devices that were involved in the incident and sequester them, as well as any disposables and consumables, which a lot of times that doesn't happen and they get thrown away before we get to the scene. We want to gather all the data we can, look at the settings on the device without changing them at first, take photographs, determine who you might want to talk to about what happened, then analyze everything, do your testing of the device, probably a full, possibly a full PM, definitely a full functional check, attempt to duplicate the issue, review the device history, review any prior incident reports to detect any trends, and not just to detect any trends that may have happened with that particular device or with other devices of the same category or make and model in your facility, but check that mod database and see if there's any similar incidents that have occurred there. Identify your root causes and contributing factors, and then finally develop your report and your report for not only locally but to the FDA as well. Okay, so what's a go bag? This is a go bag. We want to have all the contents that we would need to respond to an incident readily available to grab in the department and go. Or maybe most of these items or all of these items are on each individual work cart that gets taken to different areas. So most of these items are readily available or can be ordered very easily. You want to have a camera. Now, a lot of us have work phones and that can be used as well, but you do not want to take pictures or video when it comes to an incident with any personally owned devices, because legal can get involved and they sequester your personal phone then, and you don't want that to happen. You want to make sure you have a flashlight as well, and biohazard bags, PPE, make sure you've got your gloves and a mask if needed, or any other PPE, shoe covers, maybe throw a bunny suit in there. You want to have zip ties, defective equipment tags, investigation forms, emergency contact lists, and then a multimeter is always a good idea to have on the ready to respond to an incident, as well as a ruler, tape measure, caution tape, notebook, and the bag to put it all in. Okay, so first we want to talk about securing the area. We want to make sure we discreetly isolate the incident, minimize damage to devices, disposables, or consumables. Use barricades, preserve all your evidence as much as possible, and really, educate your clinical staff to not throw away the disposables and consumables, because those are very important parts of any incident investigation. Of course, use your PPE and lock out, tag out any devices that could have been involved that need lockout, tag out. All right, this is a defective for use tag. From your slides, you could easily just duplicate this and print it out and start using it. But it has all the critical information for staff to know that they should not be using that device. Okay, we want to identify potential witnesses, anyone who was a part of the scene, any physicians, nursing staff, medical technologist staff, or you may or may not interview the patient, usually not, but sometimes that could occur. But look for all witnesses, including those who may have seen, heard, or smelled anything that explained the incident. And then we want to collect our evidence and record our data, use the tools from the Go Bag, collect, tag, record, and photograph all the evidence possible. And then we're going to sequester the device and any consumables, disposables. At first, we don't want to alter the device in any way. We don't even want to look at the logs, just capture what is there. Preserve all the device-related items, such as any accessories, consumables, disposables, the packaging for consumables and disposables as well, because you're probably going to want that lot number. And do not change the settings or position of the device. Don't change control settings. Don't shut down, plug, or remove any batteries. Do not clean it at first. Store and transport the device carefully, and do not return any device to service until it's been properly tested and cleared for use. And of course, again, use your PPE. You want to establish a chain of custody. So, who has the device that was in question, and, make sure that everything is properly handled. You want to keep your sequestered devices and related items, including your dates and times and signature of the person responsible for the device. So having kind of that sign-off list for the established chain of custody. Store the sequestered devices in a locked area, separate from where routine maintenance takes place. And we talked about the sign-offs for chain of custody, and ensure that anyone who is encountering that device has a need to do so. All right, examine the suspect device. Sorry. Okay, so you've collected your initial findings. You've taken pictures of what the device looks like at the scene or devices, and now it's time to really examine it. So prior to testing, obviously document all those settings. At first, I know it can be a knee-jerk reaction to call the manufacturer right away, but we want to collect all the data we can prior to engaging with the manufacturer. So don't let the manufacturer just come in immediately and take any devices. We have had instances where, for instance, in the cath lab, perhaps the vendor was present, maybe Medtronic we'll use as an example, was present for the incident, and they're like, oh, let me take that with me. I'm going to take it back to my facility or to the,
Factory.
the factory, and we'll figure out what's wrong. Don't let them do that. You want to collect all your data first, so that you know they're not altering anything, and that you get the true story. Okay. Investigations can be significantly aided by the manufacturer once we do all of our testing and collect the logs and evaluate them and do our functional checks. In catastrophic incidents where significant unpredictable failure resulted, consider arranging to examine the medical devices with the representation from the manufacturer and the facility at the same time. You may need to have general counsel or legal counsel involved as well. All right, and then conduct your interviews. So you've got all your device information, you've gone as far as you can with that. You looked at your IFUs and service manual information, maybe in OneSource if you use OneSource, and or whatever, wherever you store your manuals. Now it's time to interview those who are involved. So you want to talk to each witness separately, because you don't want groupthink to start being engaged. And you want to begin the interview with assurances that all those present are being interviewed to gather facts, not to place any blame. Focus on the who, what, where, when, why, and document all of your responses, of course, and avoid bias. So there's this thing called like the halo effect. I don't know if any of you have heard of that. But the halo effect is where like, oh, Hank has 50 years of HTM experience. He knows way more than I do. He is always right.
Wow, I never hear that at home.
That's the halo effect. Hank is not always right. All right. So you don't want to make any assumptions like that. Just because someone has more experience, or they're the physician and you're a biomed tech, don't assume anything, and don't just assume that they know everything and know all the answers, because we all have to learn from each other in every way, shape, and form to get to the root cause and prevent these issues from happening again. All right, and then we want to review our device data. So review all your history records, any information you can gather from the MAUDE database, identify your patterns and trends, call your friends, have they had anything similar happen? Call your local biomed association friends, or if you're in the VA, other VA hospitals, or and find out as much as you can. And then analyze all your data for completeness and accuracy. And the last step is to prepare your incident report. So you've gathered all your data. We want to document our key facts regarding the incident investigation, prepare the written report, share summaries. Make sure you're collecting that patient safety story. What happened? What are the lessons learned? What were the outcomes? And how do we prevent it from happening again? And present those stories to leadership, perhaps through your monthly environment of care committee. All right, and I'm going to hand it back to Hank to finish this up.
So it's very rude for me to correct my co-presenter, but I really only have 1 year of experience that I've repeated 50 times. So keep that in mind. What I do love about my job is I'm learning something new every day. I picked up some tidbits yesterday that I can bring back and enrich myself, if you will. So again, I don't want you to just leave here thinking that the VA is the only source of information on incident investigations. ECRI has a very good course that you can subscribe to and attend. Some of the folks, Shelly's the chairperson of our patient safety work group in the VA. So it's a multidisciplinary group, and we sent a few of our committee members to that course. And again, they've got a wonderful set. They have a 7-step program, no different. The government, we tend to expand it, so we have a 10-step program, but they have a 7-step program. It's a very good program. And so I talked to Barbara before this session began. If it's a very serious incident, you may not want to investigate it in-house with, you're the group that takes care of the equipment. You say you have a contract services, you're the one that takes care of the equipment. Does the hospital want you to do the investigation? Would you perhaps cover up your problem? So you may want to hire somebody like ECRI or Matt Baratak or Frank Painter or Sigma Health Consulting to come in and do the investigation, so you have a little bit of a distance from the investigation. So again, this is their 7-step plan, very, very similar to what the VA, and again, I want to stress the VA, we don't worry for my VA colleagues or DOD in the room. Again, our legal is much different than in the private sector. In the private sector, they're much more they're much more rigorous. I shouldn't say serious, much more rigorous about chain of custody, keeping the equipment intact, because there will be a lawsuit. And often that equipment will never be used again because of the length involved with lawsuits. The other thing I wanted to point out to show you how important incident investigations are, this just broke on my way down here. Amy has published a guidebook on incident investigations, and actually today at, I think it's 2 o'clock, Matt Baratak and Aaron Sparrow, who used to work at ECRI, are putting on a seminar on incident investigation. So this is a very timely topic for us. And I think, to me, I love it. It's the best role I've had in my 50 years of experience. All right, let's see what we have next. All right, so this is the data. This is, so what if all this, for 12 years, Shelly and I have mined the VA with all these incidents and all these investigations. And so now we have some information to share with you. And please speak up if you're surprised by some of the devices or surprised by some of the information we've come up with. And Diana, again, thank you for putting all this together for me. So this is by fiscal year. You can see I started in 13 with Shelly, working with Shelly on this at Sigma. And you can see the variability of incidents that we've had over the years. Now, if you notice, there's a big dip in 21 and 22 and even 23. We know that was COVID. And so perhaps people are too busy to report incidents. But I want to share with you, because we're not necessarily nurses, you may not be aware of what happened down in Vanderbilt in Nashville. One of the nurses killed a patient with a medication error. It was a horrific incident. To her credit, she fessed up to it. I made a medication error. Share no blame. She reported it to the hospital. For whatever reason, they decided to prosecute her. And that sent quite a chill to the patient safety community, to the nursing community. She wasn't given any jail time. She was given community service, et cetera. But it created quite a chill in the community. And I think that, this is only Hank's opinion, I think that accounts for the dip in incident investigations more than COVID, frankly, because I know it affected every one of our patient safety managers in the hospital because they were worried. And I'm glad to, and as you can see with the spike we've had, Shelly's worked unbelievably hard with our National Center for Patient Safety, with the patient safety managers, the field at headquarters, to get the reporting back on target. And as you can see, we actually get a little bonus if we get over 100, and we're on track the past 2 years, and we're on track this year to have over 100 incidents being reported to us. And again, that number is relatively low when you think about the span of the VA. But again, those are only the ones that are being sent to us that may have national implications. At the site that does an investigation, okay, that was just something local. We know it was local. And when Shelly talked about the halo effect about bias, I actually thought she was going to give the example I like to use, is that the nurses are knuckleheads. That's my bias. When I'm called up that there's an equipment problem, my immediate bias is the nurse didn't know what to do, because our equipment is very, very reliable. And so you have, that's my biggest bias. And I don't know what I like the halo effect though. That's another good one. All right, so this is in FY26. The government goes by fiscal year, so our data is from October 1st to September 30th. It's still a calendar year. I don't think you'll be surprised by anything. Let me make sure I step out of the way. Telemetry monitors, EKG machines, that was the number one. We had 7 incidents in 26. And then you have EKG machines with Muse issues. The VA, for whatever reason, we have a problem with our Muse system where the clinical staff take the EKGs successfully from the on the EKG machine, but to forget to hit that transmit button or forget to make sure that it did get transmitted properly. So we kind of have a separate category for that. And then beds, stretchers, carts, endoscopy, OR surgical lights, and issues. Any surprises of what's not there? Yeah, infusion pumps, right, infusion pumps. For whatever reason, we've done a good job educating our staff on the safe use of infusion pumps, at least in 26. I think in some future years, you'll see infusion pumps show up.
I don't know about that. I think our lack of infusion pump incidents has to do with
Lack of reporting.
what.
Go ahead, what and why?
Because nursing staff are so burnt out on infusion pump issues, and the VA was delayed in getting all of the BD Alaris pumps replaced due to legal complications. We had to get legal involved to be able to accept pumps at no charge, and there's always a lot of competition and protests that go into buying new infusion pumps, and so every manufacturer wants our business, and that goes for everyone, not just the VA. But I believe the lack of infusion pumps is due to there's just been so many problems over the past 6 years with the BD Alaris pumps, and there's been such a long lag in getting new pumps in that they're just tired. They're not reporting them. Yeah.
25, again, another year of data. You'll still see we have monitors, EKG, beds and stretches, endoscopy, but we do have, at least we did show a couple of infusion pumps. And as I go through these bar graphs, which we've just recently, really, thanks to my Sigma colleagues, put together a lot of these reports to really look at trends, we're starting to do actionable items. When we look at beds and stretches, for example, we're just not reporting that data. So what are we doing? Shelly's being proactive in looking at our beds, because most of the bed problems are the power cords get caught up in the bed as it gets lowered. So we're looking at bed cord management gadgets to see if we can reduce that through nursing ed and through these gadgets and engineering control, not just the user control. So that's the beauty of keeping data like this, is we can start to be more proactive. Again, you'll still see, look at telemetry. We're going to have to figure out what we're doing wrong with monitors and EKGs and telemetry. Endoscopy just always seems to be a problem. Back 2 years ago, we had a lot of problems with patient lists. We kind of tackled that problem through education. And so this has been very useful data for us to have to be proactive and not just reactive. And again, we've gone back even to 23. Beds and stretchers are always there. And then here you see, so Shelly, maybe you are, well, you probably are correct. The pumps and infusion pumps, we did have a few. Please, go ahead, yes. Oh, let's keep going and see if I have something like that. Thank you for that question. I'll give you the $5 at the end of the session. Let's jump, this is more of the same, so let's just jump ahead to that question. There we go. Yeah. What do you think? 50%. 50% of the work I do for the past 12 years, use issues. So I say to people, you spend so much time doing PM, you spend so much time on repairs, we're not fixing our customer. Some of these result in very serious problems. There's a dip in 26. Shelly is identified through working with the patient safety groups that we've identified. We're going to try to tackle this. I'll share with you some of the internal conflict I have is some of us don't agree that use training is part of biomed's role. And I forcibly, as much as I can now, especially as a consultant, tell the VA, no, that's wrong. You have to educate the staff. And you don't necessarily have to do the education, but you have to hire a vendor that will do the education for us and document that education. 2 rooms over, they're having a discussion of the new VA CMMS system. As soon as the VA codes a use issue, the next work order that comes up is a use education to make sure that was given. You had a question, sir? We don't have that yet. We don't have that yet. But I love the question. That'll be in our future work as consultants. I can't give it all away in the first go around, you know? I've learned how to be a consultant after 10, 12 years. Yes, sir. Speak up, please, for everybody. Yes. Yes. I can't explain a little more of that. That's what the session's doing next door. I don't know. Can you, Shelly?
No.
I don't know.
We use Nivolo for our CMMS, and it has that functionality. That's
Yes, that I know. It is automatic. It's similar to one of if a PM fails, you automatically get a corrective work order generated. So it's similar to that. I don't know the mysteries of the routine of how it works. God bless you. We're still, a lot of our VAs, so the VA system is one hospital's on DIMLS, which is a CMS system. Some of our hospitals are on Ames-MERS, which was developed in the 80s, that I never thought it would still be, and some of the VAs use Maximo and some of them use Nivolo. So we have 4 different CMS systems that Shelly and the groups have to go through to dig up data and stuff. That is being corrected now. We are going to roll out and go on one management system, which is frankly long overdue. But again, I'm thrilled with this lower number. I'm thrilled that Shelly's bosses, the HTM community in headquarters, the HTM community in the field has finally kind of drank the Kool-Aid that they agree we have to educate our users better. Technology is so complex. I don't know how many of you in the audience have bought a new car, but the technology, when I get behind that steering wheel, it just staggers me. My favorite feature is it tells me to pay attention because my eyes are closed or sit up straight, but it has, the adaptive cruise control. It has all these different settings. And I'm fairly educated. I'm an engineer. I don't know what the average consumer does. And so put yourself in the place of the nurse that studied physiology, anatomy, and now they're just thrown in with all this technology, even at the basic ward level. It's not just the ICUs anymore. All right, so again, in 25, we're doing more work, sir. Now that I've got Sigma backing with some of the work, we are studying more things of like what are these incidents in. So 14 of the devices involved high-risk equipment, 0 deaths in 25 at least, and then 38 could have resulted in serious injury. And then we have some new facts that we're capturing. Shelly mentioned smoke and fire. We've noticed a recent trend in our ORs where the physicians are putting the pencils down on drapes and activating the issue and creating fire. So we'll track that, see if that's an issue. We're also tracking when we issue an internal recall based on an incident. And we want to see when an OEM issues a recall. And so just a little bit of information on that. And then we're rolling out a new AMR at the same time we're rolling out a new CMMS. So how many are affected by that? But I want to talk about the internal recall and the OEM recall. The VA it's probably an unfortunate use of our word, but we will have internal recalls. The patient safety work group, which Shelly chairs, will come upon one of the incidents. We realize that it does affect all of our VAs, and we'll send out a notice, hey, you must do this to this device. You must do something. The manufacturer is not issuing a formal recall. That's our recall. We're doing it. 2 recent examples are a ventilator that had a circuit board that the company had a new replacement for, but it didn't meet their standard for a recall. And it does, when the circuit board blows, creates smoke in the ICU. And that means the VA staff, just like your staff, are probably trained to pull a fire alarm. Well, we decided to spend the money, even though the company wouldn't issue a formal recall, we decided to spend the money to mandate in the VA to replace and upgrade that circuit board so we would prevent a fire. Got a little pushback as Biomed, we want to save taxpayer money. I said, go discuss it with your director that you want to save 120 bucks, 140 bucks a machine, but you might have a fire in your ICU. If that director doesn't throw you out of the room and say, what are you, crazy? And so we make conscious decisions based on that. We do balance the cost against what we're asking the field to do. And then of course, when the OEM does a recall, that's mandatory and the company will pay for it. So we make sure that's done. Since Shelly's been in headquarters, she's developed a closed loop system to make sure this work is captured, identified, and closed out. So if we send a recall notice to your hospital, we get notice from you when you recall automatic, and we can pull that data in real time to know if you've met the deadlines that we've established. All right, so conclusions are, I gave myself away already with the PM. We spent all this time on PM, but no more PMs or inspections wouldn't have increased the device reliability. Very few of the incidents occurred. If we had done more, would have prevented it, just not happening. So again, and I'm not really surprised, although I think we talked about infusion pumps. So my big takeaway is what we've been talking about is the training gap. I think we have to work much closer with our nursing programs to train them. And and nursing schools are identifying this. They're creating sim labs and things like that. I was talking to one of the vendors that helped set up a hospital for sim labs. Yes, sir. Yes.
Yeah.
Absolutely. No, I bash the nurses. I feel like that my cousin Vinny, my wife's a nurse, my daughter's a nurse, my sister's a nurse, my sister-in-law's a nurse, my niece. So I'm very sensitive to the nurse's perspective and how we have to get on their list for training. But it's paramount. You have to have a relationship. And I pick on the nurses because we don't see a lot of use issues in X-ray or in lab because they're technologists, they're techies like us. But we have to work with the nursing staff and the physician staff. Shelly gave a session yesterday talking about how we do see a spike of physician-related errors in July, because that's when you get all the new residents coming in and interns and stuff, and they're breaking stuff and doing stuff. So again, how do we capture that group? How do we give a class to that group to say, hey, this is what you need to do. This is how you contact us. And another comment I like to make when I do this solo, when you talk about the go bags or incident investigations, we're bringing care out to the community now. We're no longer like when I started. We were just a mothership. Everybody came to the hospital. You all have clinics you're responsible for. I'm sure you folks have clinics, not just the hospital. So what do you do when there's an incident at a clinic? You may not have biomed staff on site. So you have to educate your clinical users what to do. Leave the checklist with them. Make sure they can help you do stuff. In the VA, we don't have staff at all our clinics. We don't have staff on Saturday and Sunday. We don't have staff in the evenings or nights. That's a lot of workload that we're not there for. So as Shelly said, it's paramount to work with the clinical staff to save the consumables, to save the device. I still remember at the Boston VA coming to work on Monday, we had an overinfusion. And I had the note on my desk, and I go up to the ward to get the pump. Oh, we don't know which pump it was. I got 15 pumps I have to check now. If I was lucky, it could be 30 pumps. And so you really have to work with that off-shift staff. Part of our intern programs that we have, many of us started out as interns, is I have the interns work on an evening shift, work on a night shift, come in on a Saturday to see how different the hospital world is. Go to a clinic, spend a day at a clinic where they're on their own. They don't have our availability. So this is tough. This is tough. Yes, sir. Depending on the severity, sir. So if the incident was severe enough, every VA has an emergency cascade where we'll be called in, depending on the level. But if it's such a trivial incident, I don't know if there's such a thing as a trivial incident, but if it's trivial, they'll leave word for it, and Monday morning we'll hit the books and deal with it. No, I don't. We've not captured that data point yet. Okay, I like your idea. Thank you. I'm going to steal it. That's how I've been successful. I steal a lot of ideas. We're not capturing that. That would be useful to know. Yes, sir. Speak up for everybody. Well, they are. Some of the ventilators are critical.
Yeah.
Good.
I think the key point there is a recall, the definition of a recall, which wasn't in this presentation, but so a recall is a correction or a removal or destruction of a device. Can be any one of those three. Now, typically with consumable recalls, like your tubing sets and things, that's a complete, you're going to pull it off the shelf and send it back to where you got it from. That's the recall, the FDA recall definition for that. However, that's a remove from use recall. When it comes to our pumps, our anesthesia machines, our beds, whatever, those recalls are often corrective action recalls, and very rarely do the instructions for those recalls call for removing the device from use. You leave it in place until you can apply the correction in a timely manner, and then it's fixed essentially. But you have to evaluate the risk of taking a device out of service versus leaving it in service until you can get the replacement circuit board, for instance.
And part of the work that Shelly does with the team is when they issue an internal recall or even an external one, they come up with a timeline that's reasonable for the field to meet.
Yeah.
So we're not, although I have to say, sometimes we'll get a letter from, I think we're like Nuclear Med from GE,
Sure.
with loose bolts with the collimator that, with the, and so that you'll say this, stop use immediately. And then Shelly gets on the hotline and stop use immediately. So that very infrequently. But the ventilator example was a good one, the anesthesia waste recovery. You need those two systems to work. Those are both internal recalls. But we gave the staff enough time to order the material and to do one at a time so it did not affect clinical care. That's critical. But you have to sometimes use that judgment. We had a lithium battery explode in one of our EKG machines, and before we could deal with the situation properly, leadership said, "Oh, EKG machines are blowing up. Stop all EKGs." And we go, "No, wait a minute." And we have to get that genie back in the bottle, and that's very hard. So we've learned to really be proactive on things like that and jump on that right away. You can take the batteries out and use the machine. We've come up with an interim solution. But great question, great question. Other questions? We have 1 minute. Yes, sir.